Diverse kinds of health issues arising from various abnormalities in the proper functioning of thyroid gland and its hormones belong to a major class of disease conditions encountered by a homeopath in his everyday clinical practice. Classical homeopathic approach of prescribing merely on the basis of symptom totality alone, without making a proper diagnosis and scientific appraisal of the underlying disease, may not produce desired outcome in most of the cases, or satisfy the modern inquisitive patients. Homeopath should be a good diagnostician also, especially when dealing with patients of modern times, since in most of the cases, the patient himself in the current knowledge environment will be naturally updated with all the important scientific facts underlying the conditions he is suffering from. It points to the need for all homeopaths to learn more about the basic biochemistry of physiological processes, molecular-level pathology of diseases, master all the modern clinical skills, and get maximum acquainted with advanced paraphernalia and technologies of disease diagnosis. Thyroid gland is an endocrine gland in vertebrates, situated in humans in the front part of neck, and consists of two connected lobes. The lower two-thirds of the lobes are connected by a thin band of tissue called the thyroid isthmus. Microscopically, the functional unit of the thyroid gland is the spherical thyroid follicle, lined with follicular cells or thyrocytes, and occasional parafollicular cells that surround a lumen containing colloid. The thyroid gland mainly secretes three hormones: the two thyroid hormones triiodothyronine or T3 and thyroxine or T4, and a peptide hormone, calcitonin. The thyroid hormones influence the metabolic rate and protein synthesis, and in children, growth and development. Calcitonin plays a role in calcium homeostasis. Secretion of the two thyroid hormones is regulated by thyroid-stimulating hormone or TSH secreted from the anterior pituitary gland. TSH in turn is regulated by thyrotropin-releasing hormone or TRH produced by the hypothalamus in the brain. The thyroid hormones are created from iodine and an amino acid called tyrosine. T3 is so named because it contains 3 atoms of iodine per molecule and T4 contains 4 atoms of iodine per molecule. The thyroid hormones have a wide range of effects on the human body. Thyroid hormones increase the basal metabolic rate and have effects on almost all body tissues. Appetite, the absorption of substances, and gut motility are all influenced by thyroid hormones. They increase the absorption in the gut, generation, uptake by cells, and breakdown of glucose. They stimulate the breakdown of fats, and increase the number of free fatty acids. Despite increasing free fatty acids, thyroid hormones decrease cholesterol levels, perhaps by increasing the rate of secretion of cholesterol in bile. Thyroid hormones increase the rate and strength of the heartbeat. They increase the rate of breathing, intake and consumption of oxygen, and increase the activity of mitochondria. Combined, these factors increase blood flow and the body's temperature. These hormones are important for normal development. They increase the growth rate of young people, and cells of the developing brain are a major target for the thyroid hormones T3 and T4. Thyroid hormones play a particularly crucial role in brain maturation during fetal development and first few years of postnatal life. These hormones also play a role in maintaining normal sexual function, sleep, and thought patterns. Increased levels are associated with increased speed of thought generation but decreased focus. Sexual function, including libido and the maintenance of a normal menstrual cycle, are influenced by thyroid hormones. After secretion, only a very small proportion of the thyroid hormones travel freely in the blood. Most are bound to thyroxine-binding globulin, transthyretin, and albumin. Only a small portion of T4 and T3 travel freely and have hormonal activity. Thyroid hormones act by crossing the cell membrane and binding to intracellular nuclear thyroid hormone receptors, which bind with hormone response elements and transcription factors to modulate DNA transcription. In addition to these actions on DNA, the thyroid hormones also act within the cell membrane or within cytoplasm via reactions with enzymes, including calcium ATPase, adenylyl cyclase, and glucose transporters. Thyroid-stimulating hormone, also known as thyrotropin, thyrotropic hormone, or TSH, is a pituitary hormone that stimulates the thyroid gland to produce thyroxine and then triiodothyronine, which stimulates the metabolism of almost every tissue in the body. TSH is a glycoprotein hormone produced by thyrotrope cells in the anterior pituitary gland, which regulates the endocrine function of the thyroid. The hypothalamus, in the base of the brain, produces thyrotropin-releasing hormone TRH. TRH stimulates the anterior pituitary gland to produce TSH. Somatostatin is also produced by the hypothalamus, and has an opposite effect on the pituitary production of TSH, decreasing or inhibiting its release. The concentration of thyroid hormones T3 and T4 in the blood regulates the pituitary release of TSH. When T3 and T4 concentrations are low, the production of TSH is increased, and, conversely, when T3 and T4 concentrations are high, TSH production is decreased. This is an example of a negative feedback loop. Any inappropriateness of measured values, for instance a low normal TSH together with a low normal T4, may signal tertiary central disease and a TSH to TRH pathology. Elevated reverse T3-RT3 together with low normal TSH and low normal T3, T4 values, which is regarded as indicative for euthyroid 6 syndrome, may also have to be investigated for chronic subacute thyroiditis SAT with output of subpotent hormones. Absence of antibodies in patients with diagnoses of an autoimmune thyroid in their past would always be suspicious for development to SAT even in the presence of a normal TSH because there is no known recovery from autoimmunity. Stimulating antibodies to the TSH receptor mimic TSH and cause Graves' disease. In addition, human chorionic gonadotropin or HCG shows some cross-reactivity to the TSH receptor and therefore can stimulate production of thyroid hormones. In pregnancy, prolonged high concentrations of HCG can produce a transient condition termed gestational hyperthyroidism. This is also the mechanism of trophoblastic tumors increasing the production of thyroid hormones. Thyroid disorders include hyperthyroidism, hypothyroidism, thyroid inflammation or thyroiditis, thyroid enlargement or goiter, thyroid nodules, and thyroid cancer. Hyperthyroidism is characterized by excessive secretion of thyroid hormones, the most common cause of which is the autoimmune disorder Graves' disease. Hypothyroidism is characterized by a deficient secretion of thyroid hormones, most common cause of which is iodine deficiency. In iodine-deficient regions, hypothyroidism secondary to iodine deficiency is the leading cause of preventable intellectual disability in children. In iodine-sufficient regions, the most common cause of hypothyroidism is the autoimmune disorder Hashimoto's thyroiditis. Hypothyroidism, also called underactive thyroid, low thyroid or hypothyreosis, is a disorder of the endocrine system in which the thyroid gland does not produce enough thyroid hormone. It can cause a number of symptoms, such as poor ability to tolerate cold, a feeling of tiredness, constipation, slow heart rate, depression, and weight gain. Occasionally there may be swelling of the front part of the neck due to goiter. Untreated cases of hypothyroidism during pregnancy can lead to delays in growth and intellectual development in the baby or congenital iodine deficiency syndrome. Worldwide, too little iodine in the diet is the most common cause of hypothyroidism. Hashimoto's thyroiditis is the most common cause of hypothyroidism in countries with sufficient dietary iodine. Less common causes include previous treatment with radioactive iodine, injury to the hypothalamus or the anterior pituitary gland, certain medications, a lack of a functioning thyroid at birth, or previous thyroid surgery. The diagnosis of hypothyroidism, when suspected, can be confirmed with blood tests measuring thyroid-stimulating hormone TSH and thyroxine levels. Thyroid hormone replacement with levothyroxine treats hypothyroidism. Medical professionals adjust the dose according to symptoms and normalization of the thyroxine and TSH levels. Thyroid medication is safe in pregnancy. Although an adequate amount of dietary iodine is important, too much may worsen specific forms of hypothyroidism. Delayed relaxation after testing the ankle jerk reflex is a characteristic sign of hypothyroidism and is associated with the severity of the hormone deficit. Myxedema is a term used synonymously with severe hypothyroidism. However, the term is also used to describe a dermatological change that can occur in hypothyroidism and rare paradoxical cases of hypothyroidism. In this latter sense, myxedema refers to deposition of mucopolysaccharides in the dermis, which results in swelling of the affected area. One manifestation of myxedema occurring in the lower limb is pretibial myxedema, a hallmark of Graves' disease, an autoimmune form of hypothyroidism. Myxedema can also occur in Hashimoto thyroiditis and other long-standing forms of hypothyroidism. Characteristic symptoms are weakness, cold intolerance, mental and physical slowness, dry skin, typical facies, and hoarse voice. Results of the total serum thyroxine and free thyroxine index tests usually will confirm the diagnosis. Myxedema describes a specific form of cutaneous and dermal edema secondary to increased deposition of connective tissue components. The connective fibers are separated by an increased amount of protein and mucopolysaccharides. These can include glycosaminoglycans, such as hyaluronic acid, chondroitin sulfate and other mucopolysaccharides. This protein mucopolysaccharide complex binds water, producing non-pitting boggy edema, in particular around eyes, hands, feet and in the supraclavicular fossae. Myxedema is responsible for the thickening of the tongue and the laryngeal and pharyngeal mucous membranes, which results in thick slurred speech and hoarseness, both of which are seen commonly in hypothyroidism. Hypothyroidism is the condition that occurs due to excessive production of thyroid hormones by the thyroid gland. Thyrotoxicosis is the condition that occurs due to excessive thyroid hormone of any cause and therefore includes hypothyroidism. Signs and symptoms vary between people and may include irritability, muscle weakness, sleeping problems, a fast heartbeat, heat intolerance, diarrhea, enlargement of the thyroid, hand tremor, and weight loss. Symptoms are typically less severe in the elderly and during pregnancy. An uncommon complication is thyroid storm, in which an event such as an infection results in worsening symptoms such as confusion and a high temperature and often results in death. The opposite is hypothyroidism, when the thyroid gland does not make enough thyroid hormone. Graves' disease is the cause of about 50 to 80 of the cases of hypothyroidism in the United States. Other causes include multinodular goiter, toxic adenoma, inflammation of the thyroid, eating too much iodine, and too much synthetic thyroid hormone. A less common cause is a pituitary adenoma. The diagnosis may be suspected based on signs and symptoms and then confirmed with blood tests. Typically, blood tests show a low thyroid stimulating hormone TSH and raised T3 or T4. Goiter is a swelling in the neck resulting from an enlarged thyroid gland. A goiter can be associated with a thyroid that is not functioning properly. A goiter may be associated with hypothyroidism or hyperthyroidism, which may present with symptoms of the underlying disorder. For hypothyroidism, the most common symptoms are associated with adrenergic stimulation such as tachycardia or increased heart rate, palpitations, nervousness, tremor, increased blood pressure and heat intolerance. These clinical manifestations are often related to hypermetabolism or increased metabolism, excessive thyroid hormone, an increase in oxygen consumption, metabolic changes in protein metabolism, immunologic stimulation of diffuse goiter, and ocular changes such as exophthalmos. Hypothyroid people commonly have poor appetite, cold intolerance, constipation, lethargy and may undergo weight gain. However, these symptoms are often nonspecific and make diagnosis difficult. Worldwide, the most common cause for goiter is iodine deficiency, commonly seen in countries that scarcely use iodized salt. Selenium deficiency is also considered a contributing factor. According to studies, selenium plays an important regulatory role in the thyroid antioxidant system and immune disorders. Selenium, as one of the essential trace elements, is present in almost all immune cells, has immunomodulatory effects, and is abundant in thyroid tissue, and selenium deficiency in the body affects normal thyroid secretion. Studies have confirmed that plasma selenium levels are significantly lower in hypothyroid patients, and clinical efficacy has been achieved with selenium in the treatment of thyroid disorders. Selenium mainly acts as an antioxidant, anti-inflammatory, and it is involved in the production and activation of thyroid hormone. Selenium protects the thyroid from oxidative damage, but a deficiency can lead to an increase in the weight of your thyroid, which can be compounded by an iodine deficiency. The sodium iodide cotransporter, also known as the sodium iodide symporter or NIS, is a transmembrane glycoprotein, which transports two sodium cations for each iodide anion into the cell. This mediated uptake of iodide into follicular cells of the thyroid gland is the first step in the synthesis of thyroid hormone. Uptake of iodine mediated by thyroid follicular cells from the blood plasma is the first step for the synthesis of thyroid hormones. This ingested iodine is bound to serum proteins, especially to albumins. The rest of the iodine, which remains unlinked and free in bloodstream, is removed from the body through urine. Iodine uptake is a result of an active transport mechanism mediated by the NIS protein, which is found in the basolateral membrane of thyroid follicular cells. As a result of this active transport, iodide concentration inside follicular cells of thyroid tissue is 20 to 50 times higher than in the plasma. The transport of iodide across the cell membrane is driven by the electrochemical gradient of sodium. Once inside the follicular cells, the iodide diffuses to the apical membrane, where it is metabolically oxidized through the action of thyroid peroxidase to iodinium, which in turn iodinates tyrosine residues of the thyroglobulin proteins in the follicle colloid. Thus, sodium iodide symporter is essential for the synthesis of thyroid hormones. Perchlorate, nitrate, and thiocyanate are competitive inhibitors of the sodium iodide symporter of the thyroid membrane. These inhibitors can decrease iodine uptake by the symporter into the thyroid gland and may disrupt thyroid function. Perchlorate is an environmental contaminant known to disrupt the thyroid axis of many terrestrial and aquatic species. It competitively inhibits iodide uptake into the thyroid at the sodium iodide symporter and disrupts hypothalamic pituitary thyroid axis homeostasis. Perchlorate disrupts endocrine homeostasis by competitively inhibiting the transport of iodide the thyroid. It competitively blocks iodide from entering the thyroid by an effect on sodium iodide symporter, thus preventing the further synthesis of thyroid hormone. There are many drugs that can affect thyroid functional status in numerous ways. They may influence thyroid homeostasis at any level from their synthesis, secretion, transport or end organ action, resulting in hypothyroidism or hyperthyroidism. The list of drugs affecting thyroid function is long, with new drugs being added. The possible effect of drugs on the results of thyroid function tests should always be considered while making decisions regarding patient care. Thiocyanate is another potent competitive inhibitor of the thyroid sodium iodide symporter. Since thiocyanates will decrease iodide transport into the thyroid follicular cell, they will decrease the amount of thyroxine produced by the thyroid gland. As such, foodstuffs containing thiocyanate are best avoided by iodide-deficient hypothyroid patients. Perchlorate, a water-soluble chemical distributed extensively in the environment, has caused public health concerns because of widespread exposures to populations by ingestion of food and water contaminated with it. The perchlorate has recently been classified as a ubiquitous environmental contaminant, with detectable concentrations in many drinking water supplies and food and beverage products, and is also found as a contaminant in dietary supplements. The occurrence of perchlorate in the environment is most often attributed to its anthropogenic uses such as oxidizes in solid rocket propellants and application of Chilean nitrate fertilizers. However, perchlorate is also formed naturally by atmospheric process. The primary health concern for environmental exposures to perchlorate is adverse and irreversible neurodevelopmental outcomes mediated by disruption of the hypothalamic-pituitary-thyroid axis in the immature fetus or child. Adequate levels of thyroid hormones are essential for proper growth, development, reproduction, and metabolism. Perchlorate blocks thyroidal uptake of iodine and alters thyroid hormone homeostasis. Dietary iodine is an essential nutrient used in the formation of thyroid hormones, and if in short supply, from the blocking effect of perchlorate, a decrease in thyroid hormone production is thought to occur. For humans, under clinical conditions, perchlorate clearly inhibits thyroidal uptake of iodine. The primary mechanism by which perchlorate blocks thyroidal uptake of iodine is by competitive inhibition at the sodium iodide symporter Nis protein. The Nis protein is responsible for active translocation of both iodine and perchlorate from circulating blood to the thyroid follicle. Bidirectional passive diffusion of iodine and perchlorate also occurs between the thyroid gland and the blood supply perfusing the thyroid. Various published datasets that investigate the potential effect of exogenous perchlorate on the uptake of iodide in the thyroid and subsequent changes in thyroid hormone levels are available. Simplest mode of action for perchlorate in the thyroid that remains consistent with all available data involves competitive inhibition of iodide transport into the thyroid follicle, transport of perchlorate into the thyroid follicle against a concentration gradient, further transport into the thyroid lumen, where it may again interfere with iodide transport, and, finally, passive diffusion back into the blood. Hashimoto's thyroiditis, also known as chronic lymphocytic thyroiditis and Hashimoto's disease, is an autoimmune disease in which the thyroid gland is gradually destroyed. Early on, symptoms may not be noticed. Over time, the thyroid may enlarge, forming a painless goiter. Some people eventually develop hypothyroidism with accompanying weight gain, fatigue, constipation, depression, hair loss, and general pains. After many years, the thyroid typically shrinks in size. Potential complications include thyroid lymphoma. Furthermore, because it is common for untreated patients of Hashimoto's to develop hypothyroidism, further complications can include, but are not limited to, high cholesterol, heart disease, heart failure, high blood pressure, myxedema, and potential pregnancy problems. Diagnosis is confirmed with blood tests for TSH, T4, and antithyroid autoantibodies. Other conditions that can produce similar symptoms include Graves' disease and non-toxic nodular goiter. Hashimoto's thyroiditis is typically treated with levothyroxine. If hypothyroidism is not present, some may recommend no treatment, while others may treat to try to reduce the size of the goiter. Those affected should avoid eating large amounts of iodine. However, sufficient iodine is required, especially during pregnancy. Surgery is rarely required to treat the goiter. Graves' disease, also known as toxic diffuse goiter, is an autoimmune disease that affects the thyroid. It frequently results in and is the most common cause of hypothyroidism. It also often results in an enlarged thyroid. Signs and symptoms of hypothyroidism may include irritability, muscle weakness, sleeping problems, a fast heartbeat, poor tolerance of heat, diarrhea, and unintentional weight loss. Other symptoms may include thickening of the skin on the shins, known as pretibial myxedema, and eye bulging, a condition caused by Graves' ophthalmopathy. The exact cause of the disease is unclear. However, it is believed to involve a combination of genetic and environmental factors. A person is more likely to be affected if they have a family member with the disease. If one twin is affected, a 30% chance exists that the other twin will also have the disease. The onset of disease may be triggered by physical or emotional stress, infection, or giving birth. Those with other autoimmune diseases such as type 1 diabetes and rheumatoid arthritis are more likely to be affected. Smoking increases the risk of disease and may worsen eye problems. The disorder results from an antibody, called thyroid-stimulating immunoglobulin TSI, that has a similar effect to thyroid-stimulating hormone TSH. These TSI antibodies cause the thyroid gland to produce excess thyroid hormones. The diagnosis may be suspected based on symptoms and confirmed with blood tests and radioiodine uptake. Typically, blood tests show a raised T3 and T4, low TSH, increased radioiodine uptake in all areas of the thyroid and TSI antibodies. The etiology of the Hashimoto's thyroiditis and Graves' disease, collectively known as autoimmune thyroid diseases or AITD, remains unclear, but it is now generally believed that both genetic and environmental factors contribute to their development. Some recent findings have begun to directly and indirectly implicate the possibility of infectious agents in the pathogenesis of AITD. Classical Graves' disease and Hashimoto's thyroiditis has been shown to be associated with a variety of infectious agents such as Yersinia enterocolytica and retroviruses, while infections of the thyroid gland such as subacute thyroiditis and congenital rubella have been shown to be associated with thyroid autoimmune phenomena. AITD can be induced in experimental animals by certain viral infections. Indirect data suggesting involvement of the infecting organisms in the pathogenesis of human AITD is abundant. These observations regarding the relationship between infectious diseases and autoimmune thyroid diseases should be understood in the light of MIT explanations of miasms and autoimmune disease as chronic disease dispositions caused by off-target actions of antibodies generated in the body against alien proteins and infectious agents. Molecular imprints contained in potentized forms of thyroid-stimulating antibody or TSI, as well as molecular imprints contained in potentized thyroid-stimulating hormone or TSH will obviously work as powerful therapeutic agents against Graves' disease and Hashimoto's thyroiditis. Thiocyanate is an important dietary goitrogen. Thiocyanate is formed as a byproduct of glucosinolate hydrolysis and as the main detoxification product of cyanide. Thiocyanate blocks active ingestion of inorganic iodide by the thyroid. It prevents the enzyme thyroperoxidase, thereby inhibiting the incorporation of iodine into thyroglobulin, thereby contributing to the hyperthyroid effect of vegetables. Coupled tropic foods with fiber contain many of cyanogenic glycosides that are detoxified as thiocyanate. These plants are cassava, millet, yam, sweet potato, corn, and lima beans. The toxic degree of thiocyanate from cassava use, plus the mixed effect of iodine and lack of selenium, is thought to lead to endemic goiter and to promote to endemic cretinism in African countries. Observed in parts of Africa. Isothiocyanates are also another glucosinolate hydrolysis product that present in cruciferous vegetables. After isothiocyanates are divided, they create compounds that induce hypertrophy and hyperplasia of the thyroid gland. Goitin is present in plants as the water-soluble component. Progoitin is precursor of goitin, because it is delivered from progoitin with the assistance of thioglucosidase. High-temperature application damages thioglucosidase, so goitin cannot be produced. Goitin inhibits the thyroid hormones, that is, thyroxine and triiodothyronine. The goitrogenic effects of goitin were increasement of the thyroid gland, decreases iodine uptake by the gland, and lower thyroxine synthesis. Tea shows goitrogenic effect due to its flavonoids. The goitrogenic potential of green tea is higher than black tea because of the differences in catechine concentration. Thiocyanate is analogous to the cyanate ion, wherein oxygen is replaced by sulfur. SCN is one of the pseudohalides, due to the similarity of its reactions to that of halide ions. The thiocyanate may not be present in the plant as the free ion, but as a glycoside which is converted in the animal body to a thiocyanate. Thiocyanate and thiocyanate-like compounds arising from cyanogenic glycosides, glucosinolates, or thiocyanate interfere with iodine metabolism in the thyroid gland by reducing iodide uptake, stimulating iodide efflux, or replacing iodide by thiocyanate. Moreover, Thiocyanate and thiocyanate-like compounds mainly inhibit the iodide-concentrating mechanism of the thyroid gland by inhibiting the unidirectional clearance of iodide from the gland. Thyroid peroxidase, the key enzyme in thyroid hormone biosynthesis, regulates organification, iodination, and coupling reactions to form thyroid hormones in the thyroid gland. Thiocyanate, a monovalent anion having a molecular size corresponding to that of iodide, inhibits the incorporation of iodide into thyroglobulin by competing with iodide at the thyroid peroxidase level. It inhibits iodide oxidation and conversion, leads to inhibiting TPO activity. Moreover, thiocyanate also increases the formation of an essentially insoluble iodinated thyroglobulin within the thyroid in an iodine-depleted condition. At low doses, thiocyanate has been shown to inhibit the uptake of iodide. However, at higher doses thiocyanate in addition inhibits the incorporation of iodine into thyroglobulin. A diet rich in thiocyanate or glucosinolates, but deprived of iodide causes decreased levels of T3 and T4. Inhibited TPO activity associated with decreased concentration of iodide in the thyroid gland may be the probable reason for the reduced synthesis of thyroid hormones as reflected by thyroid hormone levels in thiocyanate or glucosinolate-fed rats. Low circulating level of T4 and T3 stimulate the secretion of TSH from the pituitary by feedback mechanism, and if this condition is continued for a longer duration, enlargement of the thyroid gland occurs or goiter develops. The thiocyanate generated during detoxification of cyanide in the body is believed to interfere with iodine uptake because of its structural similarity. It increases the iodine requirement in iodine-deficient populations. The thiocyanate thus acts as an additional factor for the development of goiter in such populations. Iodine excess reduces thyroidal iodine uptake and organification or incorporation into inactive MIT and DIT, and decreases TH concentrations and the response to the TSH and TRH stimulation tests. The end result could be hypothyroidism, which is known as the Wolff-Chaikoff effect. Major glucosinolates are goitin, isothiocyanates, and thiocyanates that naturally exist in cruciferous plants such as cabbage, kale, broccoli, and green leafy vegetables. Glucosinolates are also found in oilseed crops such as rapeseed and soybean meal. They are water-soluble and derived from glucose and amino acids that contain a sulfur group. Glucosinolates can contain different side groups that play important roles in their biological activities. The hydrolysis products of glucosinolates are antithyroid and reduce the level of the thyroid hormones triiodothyronine or T3 and thyroxine 4 in animals. Goitrogens are substances that disrupt the production of thyroid hormones. This triggers the pituitary to release thyroid-stimulating hormone or TSH, which then promotes the growth of thyroid tissue, eventually leading to goiter. Chemicals that have been shown to have goitrogenic effects include sulfadimethoxine, propylthiouracil, potassium perchlorate, opanoic acid, some oxazolidines such as goitin, ions such as thiocyanate. Perchlorate decrease iodide uptake by competitive inhibition and, as a consequence of reduced thyroxine and triiodothyronine secretion by the gland. Amiodarone inhibits peripheral conversion of thyroxine to triiodothyronine, also interferes with thyroid hormone action. Phenobarbital, phenytoin, carbamazepine and rifampin induce metabolic degradation of triiodothyronine and thyroxine. Foods which have been demonstrated to have goitrogenic effects include soy, cassava, brassica, broccoli and cabbage and other cruciferous vegetables. In places where iodine deficiency exists in tandem with millet being a major component of the diet, millet consumption can contribute to thyroid enlargement, which is the start of endemic goiter. Lithium, commonly used in the prophylaxis of bipolar depressive disorder, affects cell function via its inhibitory action on adenosine triphosphatase ATPase activity, cyclic adenosine monophosphate CAMP, and intracellular enzymes. The inhibitory effect of lithium on inositol phospholipid metabolism affects signal transduction and may account for part of the action of the cation in manic depression. Lithium also alters the in vitro response of cultured cells to thyrotropin-releasing hormone TRH and can stimulate DNA synthesis. Lithium is concentrated by the thyroid and inhibits thyroidal iodine uptake. It also inhibits iodotyrosine coupling, alters thyroglobulin structure, and inhibits thyroid hormone secretion. The latter effect is critical to the development of hypothyroidism and goiter. Goiter, due to increased thyrotropin TSH after inhibition of thyroid hormone release, occurs at various reported incidents of lithium application. Subclinical and clinical hypothyroidism due to lithium is usually associated with circulating anti-thyroid peroxidase TPO antibodies but may occur in their absence. Iodine exposure, dietary goitrogens, and immunogenetic background may all contribute to the occurrence of goiter and hypothyroidism during long-term lithium therapy. Now the most important questions before us is, what is the MIT approach OFR making prescriptions for thyroid diseases, and which are the homeopathic drugs to be considered in the MIT protocol for the management of thyroid problems? Potentized forms of thyroid extract, such as thyroidanum 30, containing molecular imprints of thyroid hormones, should prove highly effective, especially in cases of hypothyroidism and thyrotoxicosis, as these molecular imprints can remove the harmful molecular inhibitions produced by thyroid hormones upon various biological targets. Molecular imprints of pituitary extract and TSH should be part of MIT prescriptions for various thyroid diseases. Molecular imprints contained in potentized forms of thyroid-stimulating antibody or TSI, as well as molecular imprints contained in potentized thyroid-stimulating hormone or TSH will obviously work as powerful therapeutic agents against Graves' disease and Hashimoto's thyroiditis. The latter effect is critical to the development of hypothyroidism and goiter. Goiter, due to increased thyrotropin TSH after inhibition of thyroid hormone release, occurs at various reported incidents of lithium application. Subclinical and clinical hypothyroidism due to lithium is usually associated with circulating anti-thyroid peroxidase TPO antibodies but may occur in their absence. Iodine exposure, dietary goitrogens, and immunogenetic background may all contribute to the occurrence of goiter and hypothyroidism during long-term lithium therapy. Now the most important questions before us is, what is the MIT approach OFR making prescriptions for thyroid diseases, and which are the homeopathic drugs to be considered in the MIT protocol for the management of thyroid problems? Potentized forms of thyroid extract, such as thyroidanum 30, containing molecular imprints of thyroid hormones, should prove highly effective, especially in cases of hypothyroidism and thyrotoxicosis, as these molecular imprints can remove the harmful molecular inhibitions produced by thyroid hormones upon various biological targets. Molecular imprints of pituitary extract and TSH should be part of MIT prescriptions for various thyroid diseases. Molecular imprints contained in potentized forms of thyroid-stimulating antibody or TSI, as well as molecular imprints contained in potentized thyroid-stimulating hormone or TSH will obviously work as powerful therapeutic agents against Graves' disease and Hashimoto's thyroiditis. Since halides or binary compounds containing halogen elements such as iodine, chlorine, fluorine, bromine etc. has been proved to produce functional iodine deficiency by acting as competitive inhibitors for sodium iodide symporter or NIS by molecular mimicry, molecular imprints of these elements contained in their potentized forms will act as highly effective drugs in some types of hypothyroidism. If we go through the materia medica of these elemental drugs and the binary compounds, we can see a lot of symptoms pointing to their actions upon thyroid. Homeopathic natrum mer-30 or molecular imprints of sodium chloride, as well as lithium-30 also should be given an important place in the MIT protocol for thyroid diseases. It is well established that perchlorate, nitrate, and thiocyanate are competitive inhibitors of the sodium iodide symporter or NIS of the thyroid membrane, and these inhibitors can decrease iodine uptake by the symporter into the thyroid gland and may disrupt thyroid function. Obviously, molecular imprints of potassium perchlorate, potassium chlorate and various nitrates can act as effective homeopathic remedies in thyroid-related diseases. Potentized forms of various cyanogenic vegetable drugs such as cassava plant that contain large amounts of thiocyanates should be useful in the treatment of thyroid diseases, as molecular imprints of thiocyanates will be present in them as their active principles. A lot of such cyanogenic plant drugs are given in homeopathic materia medica. Potentized selenium also may be incorporated into the MIT protocol for thyroid disorders. Goitin present in various plants as a water-soluble component was proved to inhibit the thyroid hormones, that is, thyroxine and triiodothyronine. The goitrogenic effects of goitin were increasement of the thyroid gland, decreases iodine uptake by the gland, and lower thyroxine synthesis. As such, potentized forms of plant extracts containing molecular imprints of goitin will be an excellent therapeutic agent in the treatment of thyroid diseases. Amiditone is an antiarrhythmic medication used to treat and prevent a number of types of cardiac dysrhythmias. Amiodarone has been proved to compete with iodine in binding with sodium iodide cotransporter, also known as the sodium iodide symporter or NIS, thereby preventing the absorption of iodine into the cells. As such, molecular imprints of amiodarone, prepared by homeopathic potentization of that drug, could be utilized as an effective medication for certain kinds of iodine thyroid diseases. As it is found that chorionic gonadotropin or HCG shows some cross-reactivity to the TSH receptor by molecular mimicking, and stimulate the production of thyroid hormones and produce hypothyroidism, molecular imprints contained in potentized human chorionic gonadotropin will work as an effective drug in certain forms of hypothyroidism.